And then that segues into the next section where we're talking about recently approved treatments for sickle cell disease. So we are in a good place this year. We've had 2 drugs approved by the FDA for sickle cell disease, and we're very excited about that. The first one is Crizanlizumab, and the second one is Voxelotor. And so I want to start with Matt first, and then Julie chiming in. There's a lot of buzz during the ASH symposium this year about the results of the studies that led to the approval of Crizanlizumab. So first, starting with Julie, tell us what Crizanlizumab is, how it works, and then I'll have Matt talk about some of the abstracts that are going to be presented at ASH.
So first you have to learn to say Crizanlizumab, and it's
10 times backwards.
And Crizanlizumab is also now known as Adakveo, now that it's FDA approved. And Adakveo is a P-selectin inhibitor. So selectins are actually all through the blood vessels and on several other cell types like platelets and white cells, specifically leukocytes. And what they do is act as hooks or sticky proteins that attach cells to the inside of the blood vessel. Now, of course, when you're bleeding, you want those cells to stick so that you can stop bleeding. The specific one that this drug targets is called P-selectin. It's on both platelets as well as the inside of the endothelium or the inside of the blood vessel. And by decreasing the stickiness or blocking that P-selectin, it allows the blood to flow more easily so that even if the cell is sickled, it can still flow without occluding or stopping that blood flow.
Kind of like grease in a tube.
Yeah,
like Jiffy Lube.
Exactly. Yeah, it is. It helps the blood flow and prevents the blood from sticking. And so that's how it works. And what we've seen over time in many different places is that in mice, if you inhibited P-selectin, those sickle mice with P-selectin, if you inhibited the P-selectin, they didn't have any vaso-occlusive events. So they developed this medication and tested it initially in the SUSTAIN study. That was actually published a few years ago and presented at ASH. And in the SUSTAIN study, it was a randomized, double-blind, placebo-controlled study in which individuals were randomized to receive either a higher dose or lower dose of Crizanlizumab or placebo. And we found that in the higher dose group, crisis was reduced by almost 50%, 47%, so fairly dramatic. Yeah, and then some more recent studies where we looked at the PK and PD, we looked at how well the drug lasted in the body. We were actually able to see great successes, which led to the approval.
Okay. And it's not just in SS patients. It's not just in S-beta-0 thal patients. It was effective in all genotypes.
It was the first study that's actually been approved for all genotypes and for ages 16 and up. And it was actually effective in across the board as to not just in different genotypes, but if patients were already on hydroxyurea and they still had breakthrough pain crisis, it still reduced that pain. And we saw a 30% decrease even in patients already on hydroxyurea.
So Matt, can you talk about the safety profile of this new drug, Adakveo, for sickle cell disease, and also what have we noticed in terms of specific organs and how it has either helped or not helped specific complications of sickle cell disease?
So presenting abstracts here at ASH are quite interesting. They're trying to build on some of the outcomes from the SUSTAIN trial and where they showed a reduction in vaso-occlusive crises. One of the abstracts here is actually looking at the decreased rate of hospitalization. It wasn't statistically significant. However, it was certainly favorable in terms of reducing hospitalizations themselves. The safety profile, also a grouped abstract here looking at not only the SUSTAIN data, but a subsequent open label trial in adults looking at a slightly different formulation of the monoclonal antibody, seemed to mimic the overall generally good safety and low rate of adverse events in patients. So it's like many biologics, it's quite well tolerated from that point of view and is administered like many biologics monthly. In terms of other trials, the sponsors have gone on now to look at potentially specific organs, and so one of the abstracts here is looking at Priapism. Priapism is one of the complications of sickle cell which really does not have very good therapeutic options, and so it's exciting that this is potentially a new therapeutic intervention for that complication. They're also looking at the chronic renal failure or the progression of renal disease, which is a well-known early indicator of morbidity and mortality in adults. So it's exciting to see them not only moving from vaso-occlusive events, but also into these chronic organ damage or complications which aren't typically have a good therapeutic options.
Because patients actually die from renal failure, right? And there's significant morbidity from having priapism and erectile dysfunction. Can you speak about the Spartan study specifically? So there was a study looking at priapism. What is the inclusion criteria? What are they looking for? Because we really want to let the community know that if you have patients with sickle cell disease who have recurrent episodes of priapism, there is a study open to try to see if this medicine will help reduce their priapic events.
Well, obviously you have to be a boy or a male. Anybody with post-pubertal age who has had an incidence of priapism, and this trial itself is broken up into a pre-screening, screening, treatment phase, and then post-treatment phase. And so during the pre-screening screening phase, it's almost a 4-month period. The patient has to have had 4 priapism episodes. If they graduate from that into the screening episode, for 3 months they have to have at least 3 episodes of priapism during that screening. And then they go into a year's worth of therapy if they make it through those hurdles, and then a post-treatment phase. So these are patients who clearly have to have priapism on average at least once a month to be able to qualify during that pre-screening and screening phase.
And we thought that we were not going to find that many patients, but when we began to look at our practice, easily we found 10 patients who, oh wow, we just were not asking the right questions, kind of speaking to what you were saying. If you ask, you're going to find out the information.